Thank you all for coming tonight. I'm really pleased that we're able to pull off this event with CAMO-Net, the Tony Blair Institute for Global Change, where I work at the moment, and also the University of Liverpool. Before I joined the Tony Blair Institute, I was the BBC's global health correspondent during the pandemic, and COVID taught us all that we ignore global health threats at our peril. Hopefully, nearly 5 years on from when that strange pneumonia was spreading in Wuhan, we've learnt that we need to be less complacent, that we need to listen to experts more and work out where the gaps are before the crisis hits. That's why, in a couple of weeks' time, the UN General Assembly will hold a high-level panel to discuss the problem of AMR. One of those who will be in New York is Professor Alison Holmes. I'm very lucky to have met her in lockdown because we're neighbours, and she's shown great leadership on the subject of AMR, not just since the pandemic, but way before that. She was awarded an OBE for her services to medicine and infectious diseases in 2021. It's with great pleasure that I'm going to get her to come up first of all and explain a bit more about why we're meeting tonight.
Thank you, Naomi. Really lovely to see all of you. I'm not going to do any explaining, actually, because we've got the most incredible, distinguished panel that are going to be discussing this. So I just want to welcome you all and just say it's really wonderful to see you at this event in Liverpool. And I'm so privileged to be the David Price Evans Chair in Infectious Diseases and Global Health here at the University of Liverpool. I'm truly honoured. And I would also like to just apologise for two people who would really like to be here, but they can't be here. One of those is Dame Sally Davies, who's on a plane and is preparing for the UN General Assembly and that high-level meeting around AMR, but she would have really loved to have been here. And the other is my great colleague at the University of Liverpool, Professor William Hope, who actually holds the Dame Sally Davies Chair in AMR, and who is also very sorry, but he won't be able to attend this evening. So, at the University of Liverpool, we have major programs of research addressing antimicrobial resistance, from down amongst the molecules to the issues of social determinants. And it is really, really fantastic, the breadth and depth of the research expertise here that is fully integrated with the community, with a huge amount of civic engagement. It is truly wonderful, the work that is done here. We do work that influences populations locally, nationally, and internationally. We have a large Wellcome Trust funded award that we are extremely lucky to be involved in, which links research centres around the world, centres of antimicrobial optimization, and this is called the CAMO-Net collaboration. And it is so fantastic, the work that it's generating and the shared learning that's through this funded work. And at the University of Liverpool, we're also really delighted to be the host institute for the Fleming Fund Fellowship Scheme with Nigeria and Sierra Leone. So it's a fantastic honour for us to be the host institute for this scheme. And I'm also absolutely delighted to have my amazing colleague Steve Aston doing the most incredible sterling work in coordinating a very, very complex piece of work. We have the most amazing panel here for you this evening, and we also have the most amazing MC, who I'm going to hand back to right now. Over to you, Naomi.
Thank you, Alison. We're very honoured tonight to be able to welcome the Minister for Public Health and Prevention, Andrew Gwynn. Sadly, Andrew can't be with us in the flesh, but he's going to join us, hopefully, if the technology works, by video link. Andrew has been MP for Gorton and Denton in Greater Manchester since 2005. Like everybody else at Westminster, he was probably banking on a quiet summer, but politics had other ideas in store for him. He has a dizzying array of responsibilities, including family health, diet and obesity, pandemic preparedness, AMR, and just for good measure, chemical, biological, radiological and nuclear threats. No pressure, Andrew. Please welcome the Minister by video link from Westminster.
Thank you very much, Naomi, and it had been my intention to be there in person, but there were votes today and the whips wouldn't let me go. But hello, everybody, and it's a great pleasure to see you there in Liverpool to discuss what I think is a matter of such importance, not just for us in the United Kingdom, but for the entire world. I don't think that AMR gets anything like the attention it demands in our national and international consciousness. And let me tell you why. Here across the United Kingdom, AMR may have been responsible for well over 7,600 deaths in 2022 alone. And it cost the NHS almost £200 million every year. Now, here's an uncomfortable truth. AMR is now killing more people across the world than either HIV or malaria. It kills well over 1 million people a year, mostly from poorer and developing countries where infectious diseases are still taking a terrible toll. Now, I know that CAP has been telling some of their stories through first-class journalism at The Guardian, and tackling AMR is one of my top priorities as a new health minister. AMR is also linked to conflict and displacement, with high rates of resistance present in places like Ukraine, Gaza and Sudan. You might remember the poor Ukrainian soldier who was flown to the UK for treatment, only to be told that his leg would have to be amputated because AMR had made regular antibiotics ineffective. Cases like that should make us all stop and think, because if we don't act, the costs of treating resistant infections could compare to having a pandemic like COVID-19 every 5 years. At home and abroad, we need to do better. We must act to prevent, to diagnose, and to treat infections in poorer countries and save lives. This will protect us all by helping to reduce the risk of an untreatable infection emerging and spreading to the United Kingdom. This very month, world leaders will be convening in New York for a high-level meeting on AMR. We have a critical opportunity to secure and agreement and ensure that countries across the world stand by their commitments to stamp out AMR. We owe this to countries who already are battling AMR, and under this government, the UK will make sure that their voices are heard wherever and whenever we can. That's why this year we're working alongside our international partners to negotiate a political declaration at the high-level meeting, one that promotes fair and equitable access to safe, effective and affordable antimicrobials, including antibiotics. And we'll make sure that this is done in line with WHO guidance on which antibiotics should be deployed first to ensure these vital medicines continue to be effective. But I think we need to think bigger and give AMR the attention it deserves on the world stage. And that's why the UK is pushing for the launch of an independent science panel to set clear targets and to help nations around the world hit them. So after the high-level meeting, we must work together to implement every commitment. And we all have our part to play: governments, researchers, clinicians, and NGOs. Because if they're not put into action, the declaration will be just words on a page. And We can't afford, and I'm not going to let that happen. This government will play its part by funding new research into the economics of AMR in partnership with the World Organisation for Animal Health. This will come up with new evidence on the economic burden of AMR to inform, I hope, effective policy making, particularly around farming. And we will continue to take action to counter AMR here at home through our refreshed National Action Plan. And this is where I believe Liverpool comes in. And I think we should pay tribute to a city with a history of leading public health initiatives, from the creation of the UK's first municipal public health department in 1847 to one of our first tuberculosis mass screening programmes in 1959. The Pandemic Institute in Liverpool is a fantastic institution that brings together academic, civic, and health partners, driving research into AMR and keeping the city at the forefront of tackling emerging infections and pandemics. Louise, you are part of an institution that is leading the way, not just in the UK, but around the world, in finding solutions to AMR, from developing biodegradable drug delivery platforms that are specific to individual patients to driving microbiome research. And I'm proud that this government will do its bit to help fund the University of Liverpool's research through UKRI. I also want to pay a tribute to the AMR Citizens Jury, which is getting ordinary Liverpudlians involved in the fight against AMR. That's locally. Nationally, alongside our work to put AMR at the top of the international agenda, we're working with South Africa to build a sustainable surveillance system, helping developing countries to build laboratories, infrastructure, and data sharing capabilities. And our investments are already paying off, and both sides benefit. For example, we helped South Africa build a sustainable surveillance system, and they helped us by mapping the beta COVID-19 variant through genome sequencing. During the first phase of the Fleming Fund, we provided support for more than 240 laboratories, funding over 25,000 training attendances and 170 Fleming Fellows. The Fleming Fund is also in partnership with Liverpool University to offer fellowships to Nigeria and Sierra Leone. And as I mentioned earlier, we're also acting here at home. Our new National Action Plan sets out an ambitious path, one that strengthens our commitment to preventing infections, making the best use of antimicrobials, and investing in life-saving research. This is part of our mission to build a health and social care system fit for the future, while supporting both the growth and the clean energy missions along the way. Above all, it's helping us to make that vital shift from sickness to prevention. When it comes to AMR, it's sometimes said, if you don't get the bug, you don't need the drug. And that's why we're aiming for a test to treat model, which means the majority of cases, there should be an accurate diagnostic test for bugs before we hand out the antibiotics. I think in some ways the UK is ahead of the curve. Our innovative subscription model is a world first system to pay for antibiotics by subscription, based on their value to society, not on the volume of pills used. By paying a flat rate, I'll put my teeth in, by paying a flat rate price to companies for antibiotics, this model can promote the availability of high value, low use antibiotics, including novel compounds that target priority pathogens. We'll continue to support other countries to put in place pull incentives, because together we can create those incentives for industry who need to invest in developing the new antimicrobials that we will need. Now, I'd like to end by thanking the Tony Blair Institute, the Centres for Antimicrobial Optimisation Network, and this great city of Liverpool for your determination to tackle the global antibiotic emergency. On AMR, I want to reassure you, this government will lead, not follow. But we also can't get enough of experts. So I really look forward to hearing from this brilliant panel that we have today. Thank you very much.
Thank you very much, Andrew, for taking us on that journey from Liverpool to New York and back again. I'm delighted to say we do now have a panel, as Andrew mentioned, to discuss these issues wider and tease out some of the themes. If they could perhaps come and take their places up the front. I mentioned before that I work for the Tony Blair Institute for Global Change, so I'm delighted that my colleague Ryan Wayne, who's the Executive Director of Politics there, has been able to chair this panel. At TBI, we believe in championing the use of technology to solve today's biggest policy challenges, but we also want policymakers to start thinking more long-term about policy rather than just short-term fixes. Ryan is at the forefront of that, and more to the point, he's a Liverpudlian, born and bred. So when I asked him whether he'd join us, he said, "I'll be there." Thanks, Ryan.
I think what I specifically said is, can I expense the train ticket? And the answer was, yes. No, this is something I care deeply about, and I'm Ryan Wayne, Executive Director at the Tony Blair Institute. For all my sins, I am based down in London, but I still can't resist calling Liverpool home. And even just from the conversations outside, with so many of you in the audience and also on this amazing panel, I just feel so proud to have the knowledge that there are so many good ideas, so many innovators, so many people making change in this building and in this city. We haven't got that long tonight, and we've got 4 huge brains to the left of me. So let me introduce them, and let's have a conversation. So we've got, at the far left, Professor Louise Kenny, who is Executive Pro Vice-Chancellor at the University of Liverpool and an obstetrician by trade. If you look at Louise's work, you'll see a deep expertise and a real substance to it. But also I find a connection actually to the politics of the day in a very good way. That means that it's not just theory, but it's also stuff that is really challenging the conversation and necessarily thing in this city with some of the challenges that we face. We've got Kat Lay, who is a global health correspondent at The Guardian, but also worked at some big publications, including The Times in the past. Read Kat's work if you don't already. I'm a newest follower on Twitter, but also a long-time admirer. Kat manages to blend beautifully data and personal stories to bring this issue to life. And I think that's going to be something that we should explore maybe a little bit later on, because I think sometimes we miss that with AMR. It feels a little bit removed from the conversation of today. I'm really pleased to be joined by Dr. Janet Madega, who is the research lead at the Wellcome Trust on this, and again, just has a deep well of expertise and so many publications actually that are shaping this debate to a name, as well as live programmes that you're leading. And then finally, Professor Adiba Kamura Zaman, and the Scouse accent has ruined many good surnames. So I spoke to Adiba early on, and she gave me the best response to this. I said, how do you pronounce, all cards on table, how do you pronounce your surname? And you said to me, I want to be that famous, like Beyonce or Madonna, then I'm happy just to be addressed as Adiba. And I think in this world, you are the Beyonce of AMR and Global Public Health, so Adiba. Look, my first question is going to go to Louise, actually. So, Louise, we heard, I think, a very comprehensive speech and lay of the land there from the Minister. It'd be great to get your reflections on what he said, and maybe just ground it in some of the stuff that you are doing here in Liverpool.
Thanks, Ryan. Yeah, so I think the Minister really answered the first question of why Liverpool, right? Because he gave a really comprehensive history, starting with William Henry Duncan right up to the pandemic. But to put a little bit of detail on that, I think AMR is the definition of a big, hairy problem. And wicked problems like AMR really require a truly interdisciplinary approach. And I think what we have in Liverpool is a unique constellation of assets, some of which the Minister ran through, but I'll just briefly run through them again, that we've brought together to tackle problems like AMR. So, as the Minister mentioned, we've got a long heritage and very up-to-date expertise in public health. We sort of invented the concept in Liverpool. William Henry Duncan was the first officer of public health here in the city. We have massive expertise in infectious diseases. We have one of 2 tropical schools of medicine here in the city, who we work in very close partnership with. And we have a big interest in infectious diseases of the non-tropical variety that's pertinent to the city. And again, the Minister mentioned that. We have a Department of Clinical Pharmacology, and I can't underestimate how important that is. Novel drug creation, the creation of new drugs, the custodianship of it, the application is also a really key, important part of this mix. And then there's other stuff like our data science. I think Ian Buchan's in the audience. Ian has driven a huge amount of health data science intelligence that we've layered over our AMR task force to look at sensible use of current antibiotics and how we would deploy new drugs if and when they become available. We've also got other assets like the Pandemic Institute. But I think there are 2 things that are really very unique to Liverpool. The first is the really unique constellation of human assets, Alison being one of them. I mean, Alison and William's leadership have been inspirational and also key to the CAMO-Net and other successes that we've had in achieving really high-level funding and putting together international partnerships to tackle AMR. And then we've got our city. We are based in a really like you, I'm a Scouser, and so I'm biased, right? But I think wicked problems like AMR need to be tackled in real-world places. And I really do believe that if we can develop something and it works in Liverpool, it'll work anywhere. And we work in partnership with our citizens. So I think the Minister mentioned the citizens' juries that we have, where we co-create research questions that are relevant to the people that live like 2 minutes from here in Kensington, where AMR is a massive problem. So there is a unique constellation of assets. But if I had to pick out one, I'd pick leadership. It's thanks to Alison and William and Sekou, who runs our clinical trial phase 1 unit, and all the other, many of whom are in the audience, all the wonderful people that have gathered around this problem and have united to work together to solve it.
Yeah, and let's be honest, leadership can sometimes go against the grain of government. What we heard from the Minister right at the end there, though, is that he committed for this government to lead, not follow. And so if we've got this strong local and national leadership, so much centred in Liverpool, what do you think they need from government in order to scale up some of the efforts that we've got going on here?
Well, I'm going to be a bit controversial and a bit provocative now. Funding. Okay. So one of my other hats is that I chair the Northern Health Science Alliance, and in March of this year we published a report which unfortunately hasn't probably received as much attention as it should have done, because shortly after we launched it, the general election was called and we went into purdah. But that report looked at clinical research infrastructure funding across the whole of the UK. And it showed that there is a massive discrepancy. There is a huge amount of investment going into the Greater South East. I refuse to call it the Golden Triangle because I don't think there's anything golden about it. A huge amount of investment going into the Greater South East and a tiny amount going into the North. And it also gave lie to the myth that this is because of quality. Because if you look at REF 2021, which is a very independent, objective assessment of research quality across the UK, the North do research in abundance with far fewer resources than that which happens in the Greater South East. So it's not about the quality, it's just about the fact that if you put infrastructure into one certain place, infrastructure begets success, and that begets more and more infrastructure. There's a soundbite in that report that honestly, sometimes I wake up at 2 a.m. and if this pops into my brain, I cannot get back to sleep. There are single buildings in the Greater South East that have a greater annual spend on infrastructure than the entire North.
Wow.
And I can't understand that because we have massive expertise, we have lots of assets, we have the willingness, the leadership, and we critically have a population that wants to work with us. So if I could make one request, it would be funding, and funding at scale, critical infrastructure.
Yeah, and funding that recognises the expertise in the North. I think that comes across loud and clear, and you know, it's a zero cost to just recognise that expertise as well, right? Not saying that you just do that, but it's an important first step.
Yeah, absolutely. I think it just requires a bit of a sort of pause, break, and reset. You know, it is a truism that if you pour infrastructure into one area, it will be successful. And if your next round of grant applications are based on prior performance, you'll continue to fund one area. But that is a really poor use of the rest of the country. And there are all sorts of non-AMR related reasons why I think we should increase infrastructure support to the North, not just Liverpool, but, you know, all our partners across the North, because we're all in this unfortunate situation together. You know, we want health and life sciences to be the post-COVID economic recovery plan for this city. Yeah. But without that key infrastructure, it's going to struggle. Yeah.
Thank you so much. Look, we were promised a trip from Liverpool to New York. I've checked. John Lennon Airport doesn't do direct flights. But we are going to go there. We're going to try and make this trip. I've also checked the university's expenses policy. And we're going economy, but it's fine. Let's go to New York now. Janet, you are a lead on AMR at Wellcome. Wellcome is one of the biggest funders of AMR research. It funds not just the research and some of the programs that you do, but also it looks at advocacy as well. What do you want to see out of that high-level UNGA meeting on the 26th of September?
Thank you. So Wellcome has been a huge funder of AMR since 2017. And some of the work we have funded cuts across both scientific research as well as in policy. And in scientific research, some of the work we have funded is around generating evidence for action, evidence for to guide policy making. Because before we get into policy making, we need data, we need evidence to be able to guide the action and then leading to policy and change that we want to see. So Wellcome has funded quite a few research activities, and some of these have been in collaboration with the UK Department of Health, Bill and Melinda Gates Foundation, the Novo Nordisk Foundation as well. And so some of this work has come across as funding evidence, funding new treatments, but besides doing the science, also working with policymakers. So for the high-level meeting, we are working very closely with member countries. And we're working closely with member countries because we know that there are global AMR targets that have been set. But not every country is at the same level when it comes to setting AMR targets and being accountable to those, and therefore meeting those targets through bringing policy into action that can actually bring change that we want to see when it comes to AMR. And so what we're trying to do when it comes to the UN high-level meeting, first is through the projects that Wellcome funds, providing data that can guide global leaders, global AMR leaders, to realize AMR as a huge global problem. So we fund the famous Graham study that was published in 2019 that gave us the very first comprehensive estimates of the burden of AMR. And towards this high-level meeting this year as well, we will be contributing Wellcome-funded work as well to guide discussions at the high-level meeting. So some of the things we are doing is not only providing data that helps to support policy making, but we are also speaking to member states so that the global political declaration that will be released can be used to help countries to set bold targets that they can meet based on their contextual situation. So if we set a target for the UK, that same target cannot be met by Sudan or by Nigeria because their contextual situation is different. The other thing we do is try to have unified targets, but not only that, also set an evidence panel, which I think the minister also spoke about, but also establish mechanisms for political follow-up, because we know that with data, there'll be policy making. But that policy has to be backed by political support so that budgets can be allocated for AMR. So those are some of the things that Wellcome is doing, not only making a push from the global policy platform, but also funding research that provides data and evidence that can be used to inform policy making. Yeah.
Well, it sounds like a much needed contribution to the global conversations happening. I'm hearing data to inform decision making, and also being able to support different countries in order to bring their own context to the conversation. Exactly. So it's not a one size fits all. The UN has discussed this topic before, not least in 2016, where the minister warned against warm words and not action. What do you think you want to see after the UN in order to turn this from a political declaration into actual action that is changing?
So what we want to see after the UN declaration and after the UN high-level meeting is people people in decision-making positions and policy makers at country level actually taking the data and putting the data into action. Because usually, for example, in 2023 November, the IHME published results showing us the burden of AMR in low and middle income countries, mainly sub-Saharan Africa. Similar data has been shown for Southeast Asia, but have countries taken that data and actually used that data to inform action? But apart from that, we know that most countries, including the UK, most low and middle income countries have something called an AMR National Action Plan. National action plans define what should be done at the country level when it comes to AMR mitigation. There are different elements of the National Action Plan. We have surveillance, we have optimization of treatments, we have access to antibiotics, and I think there's about 6 to 8 elements. We know that the implementation of those national action plans will be a huge step towards AMR mitigation in every country. What we need to see after this high-level meeting is actually global partners supporting national action plans at the country level by providing funding together with governments of those countries to ensure that in each and every country, their local country priorities when it comes to AMR based on the National Action Plan is actually funded. Yeah. And those elements are implemented at the country level so that we can start to see change and movement in AMR mitigation at the country level. Yeah. And when we start from there, definitely there's going to be translation into the global AMR situation. Yeah. So in summary, we'd like to see support to countries to actually actualize the implementation of the AMR National Action Plans.
I think that is a very strong message. If delivery and implementation is everything in this, and a political focus and funding towards that is going to be critical. We're going to leave New York, and Adiba, we've got your private jet, and it's not because you are the Beyonce of the AMR world and global public health. It's because we're probably going to go and visit quite a few countries now, and there's definitely no commercial flights. Look, you're Vice Chancellor of Monash University and President in Indonesia. Malaysia, sorry. And you've also been the President of the International AIDS Society. Could you draw some comparisons and parallels with the fight that you've been having at a global level there, and some of the lessons that you've learned, is that you've had that can give us some hope maybe about how we can win the fight against AMR?
Yeah, I think there are indeed a lot of lessons to be learned from HIV/AIDS, not least of which what we've all been talking about is funding. I think what really made the difference with scaling up HIV therapy, but first of all, the R&D in HIV is, of course, the creation of the Global Fund for AIDS, TB, and Malaria, and PEPFAR. And what I would really like to see coming out of the UN General Assembly is a commitment to that kind of funding, because I think unless you have those big funding, it's going to be hard to push this issue forward.
Can I just ask on that then, if what comes out is a political declaration with no funding, do you think that sets us back quite significantly?
I think so. I think, there's been so many of these UN General Assemblies. There was one, I also do work in drug policy reform, and that went nowhere. There was a political declaration that went nowhere. Aside from funding, I think what we've learned from HIV/AIDS is of course political will, and it's wonderful to hear the Minister of Health here putting so much commitment in the UK to not just advance the issue here in the UK, but also to work with other governments. The other is, of course, the importance of academia and community partnership, and again, wonderful to hear the work here in Liverpool. And I think the activism that came from HIV communities has been central to how we move the agenda forward. For when you think in the 80s for a disease that was so stigmatized, so much controversy, but those affected or those at risk really push themselves forward, demanding research, demanding funding that led to discovery of antiretroviral therapies, and since then advocacy by the community has been central to the HIV response, and I think that there is a lot to be learned there. The difficulty with AMR is, I think it affects everyone, and so there's no sort of focal sort of point where people coalesce and can have that critical mass of people advocating on this single issue, and therefore I think it's important. The other lesson to be learned from HIV is to put a face, I think, to the problem. I think after the COVID pandemic, the public has probably gotten immune to the numbers that we spout, 1 million people here, 100,000 people there. But putting a face to the problem, I think, is something that the HIV world has done very well. And also celebrities, Beyonce, and influencers. We probably need to do more of this, because for the average person, it is quite an abstract thing until they're affected, until their loved ones do not have an antibiotic for a simple infection. It's not really in everyone's consciousness. So the messaging needs to be clear, needs to be widespread, and again, learning from HIV and more importantly from COVID. Yep. I think where COVID went wrong was in the messaging, like even in something so simple as masking. Yes. Had so much pushback, because I think we ourselves, scientists, were not very good, or we ourselves were not confident that it was an airborne disease, and so we transmitted that to the, pun not intended, to the public. And so the whole in Asia we were very good with masking, but when I came to London I was like quite shocked that in the tube that people were not masking, and I think that messaging could have been done better, and perhaps one thing that we could do better in the AMR sphere is that messaging.
Yeah, I think this is fascinating, and actually any whiff of indecision or uncertainty in that messaging from the scientific community, that really plays out in quite a significant way. But it's a difficult thing, right? Because during the pandemic there was a rightful pursuit of evidence and data, to your point, to support it. But maybe messaging injecting more confidence into it to the public is going to be key, and making it more meaningful and relevant. I think this is a great opportunity to bring yourself in, Kat, maybe just to tell us a bit about why you, we'll give us your analysis of how we talk about AMR. And I know that you have made, you're practicing what I think you're about to preach in terms of your coverage, but how can we do that on a sort of global scale? And what would your message be to academics, policymakers and others in the room around it?
I mean, yeah, it's a horrendously complicated topic, which is very difficult for us as journalists. We like very simple stories, and we don't have many words in which to tell them. So a page lead in a newspaper, you know, the main story on a news page will probably be around 600 words. And once you've got, you know, a few quotes in there, that there's very few words remaining to get that message across. And actually now, with the advent of the internet, we can see how much of that article actually gets read, which is very bad for my ego. So it's a question of distilling, I think, the message that you want to get across into its bare essentials, you know, its real basics, which is tricky with AMR, because are we talking about people who don't have access to antibiotics? You know, that is a huge issue. At the same time, we're saying, oh, actually, antibiotics are probably being overused. And you know, we're not talking about the same places, but it can very easily become a confusing message. So sometimes it's about injecting the humanity back into what can be a very abstract topic. The problem being that even a lot of the people affected don't necessarily know that they're affected. So it's hard to find them. People think, you know, my grandma, my husband died of cancer, and yeah, there was an infection that hastened the end, but no one in the team treating them has perhaps sat down and said, it's because the drugs didn't work. So I think, you know, I'd plead with the medical community to be very clear in their communications with people, because I think those conversations at an individual level are just as important as the stories that we can put out there in the mass media.
And Louise, do you think about this, like the communications with the public from the work that you do in the university? Because it strikes me that you are in the business of concepts and theory and evidence and masses of data, and talk about quite complicated subjects. And, you know, I've been guilty of reading the university publication, finding it impenetrable at times. But I have read some of your stuff, which I think is still academic in nature, but seems a bit more accessible maybe to the wider world. Is that a conscious choice and something that we could look at here?
Well, thank you, because that's probably one of the nicest compliments we've ever had. Because it is a very deliberate decision to try and make science as accessible as possible to the widest possible audience. Because I think, you know, if the pandemic demonstrated anything, it was the fact that we still have a lot to do to improve how we as a scientific community communicate, even actually what would be to us quite simple problems, in a way that is convincing, is transparent, comes with some degree of authenticity to the wider public. And I think masks are just a fantastic example. And it's easy retrospectively, but, you know, looking back now to the uncertainty we had in April, May of 2020 about masks, I find it just mind-boggling. So our regional mayor, Steve Rotherham, who would be well known to you guys, phoned me one day and said, look, Louise, I just need an answer on masks. And the fact that he was ringing an obstetrician, I think, spoke volumes. He said, like, you know, where is the scientific community at with it? And I said, to be honest, I don't understand where we're at with it. And I don't understand it on several levels, because even if we're not certain that it's airborne, and yet, you know, I think we probably are certain it's airborne, what's the harm of masking? There is no detrimental effect, and there is potentially massive benefits. And Steve, I remember said, are you going to trial it? And I said, no, because it would be like trying to trial a parachute. You know, no one's going to sign up in their right mind for the non-parachute arm. how wrong was I, right? Because it then became a very politicised issue, and it, unfortunately, we know what happened next. But I think the lack of really clear, honest, transparent instructions, communication around masking early in the pandemic was horrific, and it certainly cost lives. Yeah. So I think there is a lot done, but we could do a huge amount more in terms of our communication. And I completely agree about the issue about communicating, just cause. Certainly in obstetrics and gynecology, which was my day job, we know that sepsis contributes directly to an enormous amount of mortality and morbidity, but it also contributes indirectly to other causes. And I don't think we ever draw that out. We like to communicate simple facts, and AMR is anything but simple. So we've got to get better at communicating.
So as well as the high-level meeting giving us, hopefully, some sort of funding and institutional body for this, do you think there's a role for that to play in terms of setting the direction of how we communicate this? Or, I guess, Kat, it's a question for you and the way that you've done during the pandemic and tail end of it. We talked so much about it. And one of the striking things about the pandemic is that when politics and government gets involved in it, it can just lead it awry. So how do we square that with this challenge and what's coming out of the UN? Because we know a declaration that comes from the UN, it will be followed by some, but also be met with huge scepticism by others. That's the world that we live in, right?
Yeah, I think that's the legacy of the pandemic, is that misinformation has almost split people into tribes. And when I write about AMR, when I write about other big global health challenges like the Mpox emergency, I will get people on social media telling me, this is Project Fear 2.0, this is all an attempt to control the populations. And those people are the extreme end of things. But it does speak to, I think, a wider distrust, but also people are tired after the pandemic. They don't want to hear about another huge health threat. They don't want to have to think about it. So, I think a declaration coming out of the high-level meeting will be a bit of a moment. If it's just words, it's hard to get excited about covering it, and it is hard to know how to make that relevant to the individual. It comes down again. One thing that was very good in the pandemic was when we kind of learned the lesson of really taking the message down to community level. So people were talking, people were hearing it from people that they trusted. So I wonder if it's that kind of level of messaging, if the meeting can kind of produce that action on a national level and then down into communities, that is going to make more of a difference.
Yeah. So it's almost like instigating activity that runs right down into communities. And Adiba, you're so well versed in recognising that some of these big challenges that we face, and where you've been on the front line of fighting, whether it's drugs or criminalisation of drugs or decriminalisation of drugs or HIV, that they don't respect borders, and yet sometimes our politics can be too respectful of borders and they create divisions. What would your advice be in order to foster those sort of intergovernmental relationships? What are the strategies that we can employ in order to make those a success, especially in the political climate we find ourselves in, where that's not necessarily top of the order list?
Yeah, I guess you can use some of the existing structures like ASEAN or the African CDC. I think the African CDC is probably ahead of ASEAN when it comes to collaboration in infectious diseases. But at least, there's that structure to start off with. And I suppose, I know we're all sounding a bit negative about this UN General Assembly, but some of the political declaration can perhaps be taken on by those platforms. But it's also great to hear the minister just saying, that's that bilateral collaboration with South Africa on something as concrete as surveillance. So there could be more of this, but I think what CAMO-Net is doing is probably going to be a lot more effective, working from the ground rather than having political from the top. The way that the structure of the CAMO-Net in terms of the hubs and the countries that are involved are designing research and program that's relevant to them, but with the support of, Liverpool and Imperial, having worked with some of these networks, I think that's a very effective way of working. So scientists helping scientists rather than politicians.
Almost makes it geopolitical proof, but maybe that's an impossible thing. I'm going to come to the panel shortly just to get some final reflections before we go to questions. What I'd love you guys to reflect on is what does success look like at the UN high-level meeting, and what does success look like in 5 years' time? So it gives us something to aspire to at the end of September and something to work towards over the next 5 years. But I'm going to come to you first, Janet, just to pick up on this last point that we made just around countries working together and maybe what welcome does, because I know that you work across borders and you yourself do personally. What you do in order to stimulate and foster that sort of cross-country work, whether it's at a government level or at a more grassroots level?
Yeah, thank you for that. So I think what has been mentioned here is it cuts along the lines of equitable research and how we do that. And I think in the world we live in today, it's impossible for any scientist or any country to do research by themselves. And so there is a lot of collaboration that has to happen. But then when collaboration is happening, it has to be with partners. And so it just means that for all partners, there'll be mutual participation, there'll be trust, and there'll be respect for us to make it equitable. We at Wellcome Fund do that in terms of how we fund, who we fund, and what we fund. And so in terms of enhancing equitable partnerships, which is what we need in order to work effectively across geographies and across different political setups. So what we do is, first of all, we encourage the engagement of communities in research. When Wellcome is going to fund research in AMR, and that research is going to involve community participation, we have a community engagement group that will ensure that that proposal is going to ensure that communities are engaged properly, are informed, and they actually understand the basis of the research that they'll be participating in. But overall, in our AMR work, what we have done is we as Wellcome have our own strategy, but we know that our strategy might not reflect the priorities of the country. So what we have done is we have allowed countries, we have allowed researchers at the country level to approach us and come to us with their proposals that are relevant to what they'd like us to fund. Sometimes we co-create the proposal with them to allow it to fit their priorities and some of the gaps that we as Wellcome have identified. In addition to co-creation, so that we are not imposing our work or our interest at the country level, we have also ensured that where there is collaboration between high-income countries and low-income countries, where the burden of AMR is highest, we always ensure there is a balance of power, so that not all the money doesn't go to the high-income country partner. But taking the example of CAMO-Net, we ensure that each of the country-level hubs receive their own funding. So through initiatives like that, we are able to remove power imbalances. We are able to ensure that the principal investigators are not only based in high-income countries, but are also driving their own research in the low-income countries as well, because that's where we need to see change. Absolutely. And that's where the change is needed, and that's also where burden is highest when it comes to AMR. But also, I'd like to say that at Wellcome, when it comes to AMR research, we have not only done a landscape analysis by ourselves, but we have worked with a think tank called CEDRIC, Surveillance and Epidemiology of Drug-Resistant Infections Consortium. So it's a group of experts based across the world, and what they do is inform us of where the gaps are. And we rely on them to help us identify gaps where we need to put funding. And with that, we're able to fund activities that are going to be useful at the country level, so that that change can be seen at that level. So those are just some of the things that Wellcome does so that we can be able to promote equity and be able to research equity and be able to remove some of the imbalances that we see. We are only one funding organization, and we haven't been able to cover ground, but we believe that the little that we have done has been able to show and bring some change that is much needed, and which I think for people who know about some of the work that we fund at Wellcome, we are able to show evidence of some of the work that we have done, and I'm happy to talk about those later after the panel.
That's great, and I think one thing that is absolutely in demand that's coming through to me is funding, and so people in the room have got projects, initiatives. I think Janet is your person, but it sounds the work that you're doing is admirable and is building that evidence base across country, making organisations like this possible. Okay, so to wrap it up before we go to questions from our audience, we'll start with you, Louise, if that's okay. What does success look like after the high-level meeting, 27th of September? What does it look like in 5 years' time?
Well, I guess aside from the things that we've already discussed, such as putting money instead of, as well as warm words, I think success would look like meaningful progress in terms of addressing the problem. And I would say one very specific thing, and I'm clearly biased given my clinical background, but success isn't real success unless it's very inclusive and incorporates meaningful progress for all citizens. And I would just flag that in terms of AMR burden, pregnant women, unborn babies and newborns are some of the most vulnerable in our society and the most left behind in terms of drug development, drug trials, interventions, even non-interventional trials. Until very, very recently, pregnant women were deliberately excluded. And given the burden of disease, given their predilection for sepsis because of their immunocompromise, their normal physiological immunocompromise, and the global burden of disease, particularly in the countries where CAMO-Net is operating, I would like something to come out of this which is reflective so that no woman and unborn baby is left behind. Yeah,
very, very well said. Kat?
I mean, when it comes to our news coverage, I'm going to be looking for concrete commitments over just warm words, things like targets, even if they're very broad, because obviously, as we've discussed, you can't have the same target for every country, but something for the direction of travel, the creation of that independent scientific panel, and then hopefully, in 5 years' time, I will be writing about things going in the right direction, that annual burden of deaths, those economic costs coming down from what was predicted.
No, that sounds like a dream scenario that I think we all do want to aspire to. Adiba?
Yeah, I'm also going to say targets, because I think if you look at initially when the HIV movement had the 1990 targets, everyone thought, are they crazy, ending AIDS by 2030. But actually it gives governments something to hang on to, and lo and behold, we've got 7 countries in the world that's surpassed the 95 or at the 95 targets. So and the same thing with cervical cancer, that because there are those targets, there is a focus towards. So I think that's important.
Brilliant. Janet?
Thank you. So apart from the targets, for me, I'd like to see our leaders put the words into action. And much as a lot is said around what we should do about AMR, I think that there are some key areas that are lacking. For example, for you to be able to treat an infection properly, you need diagnostics. Then, after proper diagnosis, then you need the right treatment. And then, after identifying which is the right treatment, is that treatment available? So for me, I think after the high-level meeting, I'd really like to see some action around diagnostics for the priority pathogens that are key on the WHO list of AMR pathogens. I'd also like to see more funding towards development of new drugs towards the priority pathogen infections. But apart from that, I'd also like to see that the mechanisms for ensuring access to medicines in countries where burden of AMR is highest is made possible, because even though we say that the burden of AMR is highest in Africa and Asia, actually those areas burden is high because there's poor access to the medicines that are needed to treat patients who have AMR infections there. So these are the three things that I'd really like to see a change in going forward.
Brilliant. Thank you so much.
Ryan, can I just pick up, thank you, on what the Minister said that we've not had a chance to speak about, which is prevention. Yep. I think we have so many tools like vaccines and making sure that unborn babies and pregnant women have access to clean water. Those two simple things. Well, vaccines not so. They're both not so simple, but they're essential. They're critical. Yep. They exist. They don't need new science. Yep. But they're not being used in so many countries around the world. I think I read somewhere that just by expanding pneumococcal and rotavirus vaccine could reduce infectious diseases by 60. Could reduce the use of inappropriate antibiotics by 60%. Yep. And so, in a way, we already have so many tools. Just like in HIV, we have all the tools, but we're not ending AIDS because we're not using those tools that we already have, and for all the reasons that we've spoken about just now.
No, I'm glad you said that. And the thing that strikes me is you're right. We do have so many tools at our disposal. Something is going amiss with the political will. Hopefully, the political declaration can organise that and focus it. Targets are going to be key. The media is clearly going to be key. Advocacy is going to be key in terms of bringing accountability. Diagnostics are going to be critically important. And there's also a bleed across to other areas of public health and health more broadly. I think, Louise, your point about women and children is a really good example of that. And if we can start to see changes there, then it's not just AMR that we're fighting here. It's actually improving people's health across the board and the representation of people in the health system. It's everything. So we're going to go to questions now. I think we'll take them in rounds of 3. If you could just say who you are and then ask your question, that would be brilliant. If you want to direct it to one of the panellists, great. If not, we can work that out between ourselves. So any questions? Gentleman over there.
Thank you very much, panel. My name's Callum Semple. I'm Professor of Outbreak Medicine here at the University of Liverpool. This evening, we've heard a lot about the countermeasures, the firefighting. I'm going to put a bit of challenge to you. We should be fireproofing. In Liverpool, we're uniquely placed because we've got a research-active veterinary school with ecologists and epidemiologists, as well as the infection team, and that gives us a really good global health view of the problem. And the generation of this problem is from misuse of antibiotics as growth factors in farming around the world. So if we're going to fireproof, we need to reduce the generation of these antimicrobial resistance cassettes. That's a really tricky one. How would the panel push or influence that at the UN summit? Thank you very much.
Excellent question. Any more questions? No? Okay. Oh, yeah, gentleman here.
Thank you very much. Khalid Abdullah, I'm a PhD student at Epidemiology and Population Health in the University of Liverpool. Just I have a question regarding the AMR. As we know that the National Action Plans in the UK is being introduced in 2013 or 14, and it's been working fine. And the reduction of the antimicrobial use in the livestock and farming, and as well in the human being, is reducing significantly. But I have a question. will this reduction in the antimicrobial use will lead to the reduction in the AMR percentage, for example, in the country? This is my question.
Okay, so the question is, will the reduction in
the antimicrobial use in the human and animal, will this lead to the reduction in parallel with the...
That's clear. Great. Okay, and then question from the lady here.
Hello, my name is Safa Amran. I'm a PhD student at Monash University, Malaysia, but I'm here for mobility at Liverpool University. So my question is actually continuation for the question from the gentleman. Regarding the antibiotic stewardship program, how this program can help to reduce the issue of the antibiotic resistance. Because I think by applying or implementing a stewardship of course, it will not reduce totally the resistance, but it can help to use the antibiotic rationally. It's just a suggestion or maybe a comment to the gentleman there. Thank you.
That's great. So let's tackle them in reverse order then. So Adiba, maybe if you could just give us a view on the stewardship and reduction of
yeah, and I guess that the question on the use, well, we would expect with the reduction in use through measures like antibiotic stewardship should reduce antibiotic resistance, but it's not the only thing. I think, it has to be a comprehensive package in hospitals. Excuse me. I'm still a little bit jet lagged. It has to come together with infection control measures. For example, it needs to go hand in hand.
Yeah. And then bring in, was it Callum? Your question on fireproofing, and I think this is a really important topic actually, and one where legislation and regulation can play a big role. So maybe, Louise, if you could speak to that. And then also, Jen, I know that Wellcome have done stuff on legislation in this space.
Well, firstly, thank you, Callum, for reminding me that we had a vet school, and that was something that I hadn't mentioned in the list of wonderful assets that we have in Liverpool. But I think that actually illustrates the problem, right? So the disconnect between animal researchers and human health researchers is part of the fundamental problem here. And there are very few places, and you and I know this, right, that actually combine in a truly holistic, encompassing way the full spectrum of research spanning basic animal all the way through to zoonotic transmission and then into human health. You can count them on the fingers of one hand in this country, and we're probably at the forefront globally. So I think therein lies the problem and probably the solution. And, my bad, but the very fact that I forgot to mention the vet school in the list of assets, again, illustrates the issue here. It's a fundamental part of the problem, and it has to be part of the solution. It's probably a little bit above my pay grade to talk about how we can legislate or otherwise corral behaviour in terms of prescription or use of antibiotics within the food chain or within animal husbandry. But as a medic, I've always been a little bit nonplussed by the rather extreme measures we go to for some control drugs. Not all of them, but some. And yet you can buy, I was in Italy last week, and you can buy antibiotics over the counter. That is a fundamental, but you can go into any pharmacy in Italy and ask for penicillin, and they'll give it to you without even a consult with a pharmacist. So that, I think, is a problem, and it's low-hanging fruit. We need to fix that urgently.
Yeah, that's a huge problem, and if what we're saying, and have been saying for, let's face it, many, many years now, this is a global crisis that doesn't respect borders. The solutions can't respect borders either. We've got to find the mechanisms and the bodies and the political will to if need be, regulate and legislate in order to address some of those things.
I mean, I just say, I think Ishwar's in the audience, right? So Ishwar's team are working on a new class of antibiotic antimicrobial drug, right? And I'm sorry for embarrassing you, Ishwar, but and he tells me, and I read his grant applications, this is going to be the first new class of drug for about 3 decades. And we all hope it comes to pass, right? William will talk to me about the fact that before it does, he hopes we get our house in order so that we don't burn through this new drug the way we've burnt through all the other assets. We've got to put in place really, really super effective custodianship because these drugs are super, super precious. And if it's another 3 decades before the next one comes along, I mean, we will be up that creek without a paddle or a canoe in that time. So we do need to take action urgently. And
Adiba, I know that one of your work programs looks at fireproof, and I love that term. What's the view from Wellcome on that?
Yes, thank you. So, as I mentioned earlier, Wellcome funds various activities on AMR, and one of our initial projects was actually around legislation that prohibits farmers from using antimicrobials to treat animals unless they have a veterinarian's prescription. So if you Google online, you'll find something called a legislation called the California Senate Bill number 27, when the state of California in the US enacted a bill that prohibits animal farmers from using antibiotics to fatten their animals or for prophylaxis. So when that happened, Wellcome worked with a researcher from the George Washington University in the US to actually see whether that policy and that legislation was going to help reduce the rate of drug-resistant infections that are seen within a catchment area within the state of California. So the study has ended last month. Okay. And results so far show that there is some relationship between the amount of clinical infections out of drug-resistant bacteria that are seen in that catchment area in the period before the legislation compared to the period after the legislation. But most important is that the study shows there's actually a sharing of antimicrobial resistance genes between isolates from animal meat and isolates from the clinic. So clearly what this work shows is that the enactment of legislation prohibiting the use of the same antimicrobials in the human clinic and in the farm will definitely help safeguard our antibiotics. But the problem is big because in some countries, in fact, animal feed is sold already laden with antibiotics, especially poultry feed in low and middle income countries. So it is a huge problem and it will require several levels of action for us to actually ensure that we are not having animals fed antibiotics, the same antibiotics that we use to treat human infections. So it's an area that Wellcome is working on, and you can keep your eyes peeled for the paper when it's published.
I look forward to it. And Kat, how do you cover fireproofing? And is there a challenge in terms of drawing a link between some of the measures that we're talking about here and AMR when it comes to communicating those to the public, or at least those on the receiving end of those measures?
I mean, I actually think the use of antibiotics in farming is fairly low-hanging fruit with the public in terms of things that they don't like. And I don't know if that is because they're worried about antimicrobial resistance or just because they don't like the idea of drugs they didn't know about coming through in their food. So that it can be quite a good entry point, I think, to the issue when we're writing about it. I know the Bureau of Investigative Journalism has done some really good work on that in particular. I don't think people know when we're talking about you shouldn't take an antibiotic because you've probably got a virus. I don't know if that has really kind of made that link in the public consciousness, because then the drugs might not be there when you do need them. So that's probably something we could try to get across it in a slightly stronger fashion.
We're approaching the end of the evening, but we'll probably squeeze in, if there is one more question or two. Have been generous. Gentleman over there.
All right. I'm Ian Buchan. I'm a public health doctor and data scientist. My question is about data and politics. AMR is a data-hungry problem. Ever-changing, complex, requires systems thinking and a systems approach to data interaction, which the panel wisely mentioned. How will you use this summit to treat AMR as a forcing function? Bear in mind that we build data interaction systems in very pressured health systems around the world that cannot afford to build intelligence systems just for AMR in isolation. But AMR touches so many aspects of our health systems and wider, One Health systems, environmental systems, that creating solutions of turning data into action for AMR unblocks solutions in many other areas that need public health action. Does the panel think it should use AMR as a forcing function, the politics of data, and we can do better around the world than we did with sharing data in COVID-19 responses?
It's a brilliant question. So the politics of AMR as a forcing mechanism for data, Adiba?
Totally agree. I think, yeah. But it will require a lot of investment in many countries where, electronic medical records don't exist. And so back to funding.
Yeah, absolutely. Louise?
I mean, yes, is the very short answer to that question. But I know you know that, right? So, and it's not just, I think, low to middle income countries where the infrastructure is lacking. I mean, even in the UK, right, we're doing good work in silos. But you and I both know that we haven't got a national network that can do this at speed and at scale. And if you told us that that would be the situation, when we were in the middle of the pandemic, in the trenches together doing this, and colleagues around the room will know what I'm talking about, if you told us then that we would still lack the infrastructure that we need in 2024, we'd have been horrified. And yet here we are.
Thank you for that, because data is one of the things that I think is really key, not only in AMR, but other disease systems as well. I think the key word that we're looking for here is interoperability. Because as Louise has mentioned, there's a lot of silos in data. When it comes to HIV data sits in a silo. When it comes to malaria data, it sits in a silo. But often you find that the HIV patient might have malaria and might have a drug-resistant infection. So I think what needs to happen, which kind of happened well in COVID, is interoperability. Data systems talking to each other. One data system being able to feed another data system with the same information. So the one thing that is lacking, and which we experienced a lot when we were doing the GRAM1 study, was that people have data, but the data is not standardized. Metadata is available in one country but is lacking in another country. So to be able to use data across different countries, even for AMR, even for malaria, is very difficult. So I think the one thing that we need to do is standardize data capture systems, but also enhance the interoperability of those data systems so that data can be easily analyzed uniformly, but also can be shared easily. And so when data systems are unified, it's easier and more practical to be able to learn from one system to another, from one country to another. So the key word for me there when it comes to data is interoperability.
Can I be a bit controversial here? In the HIV world, this gets discussed quite a bit, and often the blame is to the funders who insist on having their data in a certain way. And so they, I agree that it needs to be interoperable, and perhaps now the computer systems are much better than what they used to be, but that siloed are often driven by the funders wanting the data collected in a certain way.
Yeah. And so interoperability is an umbrella that we all need to sit under, whether you're governments or funders or academics. I think that's a really smart point. I think Ian's frame of the question, clearly Louise knows him well because we basically gave the answer in the question very convincingly. But the fact that you called it a forcing mechanism, I think, is a recognition of the political challenge when it comes to data-driven health systems, right? And there's not always an immediate appetite for them, or at least an understanding of what they mean in practice. And I think if AMR can be talked about, something that requires a data-driven solution. And we can land some of the stuff that the panel's talked about today in terms of recognising the scale of this problem, humanising it, making it meaningful to political leaders at the highest level, but also to an ecosystem that sits underneath that. That maybe, just maybe, that is a thing that starts to unlock or create more political will around data-driven healthcare systems. Certainly, one of the things that the Institute does is we work with countries around the world. We're in 38 countries at the highest level. And there's a huge opportunity, and I think this challenge presents it, for these countries to almost leapfrog some of the Western healthcare systems with their data-driven approach, and maybe this could be a force and mechanism for it. It's really exciting. Look, I feel humbled to be sitting next to four such incredible and remarkable people and thinkers, and people who are doing stuff in this space and in many, many other spaces. I think you've brought a very complicated subject to life, but also, I think most importantly, you've injected some optimism into this, along with a necessary dose of realism. And I think that optimism for me comes from the fact that, yes, we're probably going to see a UN declaration that does err more towards warm words, but we know, and I think, Adib, you're a testament to this, that it's the people outside of the room or outside of that declaration who are the ones that bring it to life and make change happen. And whether it's on this panel or in the room in front of me, it feels like here in Liverpool we've got a real good base from which to start that. So the ambition's there. We need the mission, we need the orientation, but one thing we've definitely got is the people, and that makes you feel very, very positive from today. Thank you so much. I think Naomi's going to close proceedings, but a huge thank you to the panel. Thank you.
Yes, thank you, Ryan. That was fascinating, and thank you particularly to Adiba for flying over to join us tonight. Not much more remains other than to thank you for having us in Liverpool, and a special thanks to Chris and the team from CAMO-Net for their hard work to get the event running smoothly. And thanks again to Alison for having the idea in the first place. Whatever the UN General Assembly produces in a couple of weeks' time, at least it's risen the issue up the political agenda, and it's also meant that we've talked about it in all its complexity tonight, which I'm really proud of for everyone in this room. Thank you very much.